My name is Peyton Wiggins Courtney, and I am a Master's of Science in Nursing Family Nurse Practitioner student here at Arkansas State University. My master's level research project was focused on provider compliance rates in implementing low-dose aspirin therapy in high-risk preeclampsia patients. Preeclampsia is defined as the new onset of hypertension or high blood pressure greater than 140 systolic and/or 90 diastolic on two separate readings that are more than 4 hours apart in pregnancy, along with proteinuria and/or further evidence of end organ damage after 20 weeks gestation. According to the American College of Obstetricians and Gynecologists, preeclampsia affects 10% of pregnancies worldwide and 25% of pregnancies in the United States. The United States Preventive Services Task Force recommends that any pregnant mother past 12 weeks gestation take low-dose aspirin daily if there is any indication that preeclampsia could develop later in pregnancy or if there is a previous history of preeclampsia in past pregnancies. Patients at risk include multifetal gestation, chronic hypertension, type 1 or 2 diabetes, renal disease, autoimmune disease, advanced maternal age, previous history of preeclampsia in pregnancy, obesity, and nulliparity. The primary objective for this study was to determine if women's health providers in Memphis, Tennessee were adhering to the recommendation published by the United States Preventive Services Task Force and American College of Obstetricians and Gynecologists to prescribe low-dose aspirin therapy to all pregnant patients who are considered high risk in developing preeclampsia during pregnancy. IRB approval was obtained through Arkansas State University, and the study was conducted using a retrospective chart review, where 48 charts were reviewed via electronic medical record in an obstetric and gynecologic clinic in Memphis, Tennessee. Information for this project was retrieved from June 1st, 2019 through November 1st, 2019. Inclusion criteria for this project included female pregnant patients, first-time pregnancies, second or higher pregnancies, multifetal pregnancy, history of preeclampsia in previous pregnancies, patients considered to be of advanced maternal age, postpartum patients, and patients with a history of chronic hypertension, diabetes mellitus 1 or 2, autoimmune disease, and renal disease. Exclusion criteria included any pregnant female whose gestational age was less than 12 weeks. Of the 9 patients within their first pregnancy, 44.4% took low-dose aspirin from 12 weeks gestation until delivery, and 55.6% did not take low-dose aspirin throughout their pregnancy. Of the 39 patients that were in their second or higher pregnancy, 87.2% took low-dose aspirin from 12 weeks gestation until delivery, and 12.8% did not take low-dose aspirin throughout their pregnancy. Of the 33 patients who were of advanced maternal age, 81.8% took low-dose aspirin from 12 weeks gestation until delivery, and 18.2% did not. Of the 48 patients that are included within this study, 79.2% took low-dose aspirin from 12 weeks gestation until delivery, and 20.8% did not take low-dose aspirin when it was warranted based on past medical history or age. Though this study produced high compliance results, there is still room for improvement in ensuring that all pregnant patients at high risk for preeclampsia development are advised to take low-dose aspirin to prevent potential maternal and/or fetal harm. Low-dose aspirin therapy in high-risk preeclampsia patients has shown to decrease preeclampsia occurrence by 24%, preterm birth by 14%, and intrauterine growth restriction by 20%. Women's health providers should comply with the USPSTF recommendation with all future cases that include high-risk preeclampsia and provide patient education on the benefits of low-dose aspirin therapy. Further research is warranted on provider compliance in implementing low-dose aspirin therapy in patients that present a risk to developing preeclampsia during pregnancy on a national level. There is limited data available to compare the results that this study yielded to what women's health providers do in the instance of preeclampsia and low-dose aspirin therapy nationwide. I would like to thank Tammy Hawkins, my clinical advisor, for all the guidance and assistance she gave me in completing this project. I would also like to thank Arkansas State University for allowing me the opportunity to present this research to the faculty and fellow students that participated in Create AState.